Hello, and welcome to this session on pharmacy research methods. In this session, we're going to look at a range of research methods used in pharmacy research. As we will see, pharmacy research spans a wide range of topics, and therefore we're going to explore a range of methods and study designs. As I mentioned in the introduction, master's degrees in pharmacy are awarded to students who have demonstrated a comprehensive understanding of techniques applicable to their own research. As I mentioned in the module overview presentation, these are the topics we will be covering within the research methods section of this module. We'll be looking at epidemiology, descriptive statistics, questionnaire design, power calculation and effect sizes, inferential statistics, and there will be a range of workshops including data analysis using SPSS, literature searching, qualitative methods, preclinical research methods, and some final lectures on prescribing analysis and health information, and systematic reviewing and critical appraisal. And we'll also have one session where we look at a paper in some detail, and that will form part of the examination. So there are three reasons for understanding research methods and developing research skills. Firstly, that you may need to give advice to patients based on your interpretation of the research evidence. Secondly, for your own project. And thirdly, because in an increasingly competitive world, research skills are valued. One point to mention is that real-world data are increasingly being used to inform our understanding of data, and this is something that we're going to be looking at later. Think about the amount of medicines that the average person consumes over a lifetime. It's been estimated in the UK that the average person receives about 14,000 prescribed tablets over their lifetime, and if we include over-the-counter medicines, then this increases to 40,000. That's a lot of medications, and there are a number of questions regarding this level of medication use, and that's what we're going to be exploring in the rest of the research method sessions. Let's look at an advert for a product in a newspaper that some people might consider to be a medicine. This product is called Neurosan. It can be bought in a pharmacy and it's endorsed by a professor of pharmacy. So imagine somebody comes into the pharmacy and asks for your opinion. What research has been done? So the first thing you might do is look at the website. And according to the website, Neurosan has been scientifically developed on the basis of extensive worldwide research. Neurosan combines the latest research-based micronutrients for brain health, and it provides a comprehensive range of micronutrients, including 5-HTP, which is an important precursor of serotonin, which supports numerous functions, including mood, memory, and learning. So on the basis of it, it looks like there might have been research and some people might accept this. However, the next step might be to turn to the scientific literature. Has anything actually been published in the scientific literature? The first step might be to look at a source like PubMed, where papers are published. And so we type in Neurosan and we find that nothing comes up. There appear to have been no studies. So unlike many other drugs which have randomized controlled trials or observational studies, there doesn't actually seem to have been any studies, or at least nothing published in the literature. So we might then think, well, what about people's personal testimonies? So we could look on Amazon and we could see there would be a range of reviews. And I'll just read you a couple of the reviews here. So the first person says, I've been using the product for about 2 weeks to help me concentrate. I've noticed that my memory has improved, and oddly enough, I'm starting to remember many things I thought I'd forgotten. I guess it may help transmitters in the brain to recall information. And it goes on like this. The second person says, I took it for a month and saw no effect. Maybe I concentrated a bit better, but would not use it again. I suppose everyone had different experiences with it. So could we conclude this to be valid research? Well, it's not really research, is it? It's just people reporting their opinions. And now we need to begin to think about all the factors that would be involved in a good research study. First of all, this is only a sample of 2 people, so clearly it's a very small sample. But what happens if there was 50 people? Would it be acceptable? So you might want to think about, are these 50 people representative? They're not representative, are they? Because they're people who have chosen to make a review, and it could be that people who have positive experiences are more likely to report their experiences. So the first thing to recognize is the quality of evidence here is very low. The outcomes, there's no real outcomes in terms of well-defined outcomes. There's no comparison with placebo, so we don't know, for example, if they hadn't taken the Neurosan, whether they would have noticed these changes. So generally, we would consider this level of evidence to be fairly low grade. In the introduction, we looked at the example of a prescribed drug, Avandia. Avandia is used to control blood sugar in type 2 diabetic patients. It was licensed by the European Medicines Agency in 2000, and more than 100,000 patients in the UK have used it despite concerns about heart problems. In 2010, the European Medicines Agency recommended that the drug be suspended because of these issues, following a meta-analysis in the New England Journal of Medicine that linked the drug's use to an increased risk of heart attack. Later in this session, we're going to be looking in more detail at meta-analysis, but for the time being, the important point is that research on benefits and risks can have a big impact on drugs that are available for prescribing. Let's look at another example. Paroxetine is a depressant of the SSRI class. It is used to treat various types of depressive disorder. In a reanalysis of the original trial, published in the British Medical Journal, the authors say that the beneficial effects of paroxetine on young people were far less, and the harmful effects were far greater than the original study suggested. Out of 275 children in the trial, 11 taking the drug and 1 in the group given a placebo developed suicidal or self-harming behaviour. David Healy, Professor of Psychiatry at Bangor University, said it was hard to see how so many suicidal children could have been overlooked. We think if you were to go in and look at this data, even without training, and find that there were at least 12 children becoming suicidal out of 23 given the drugs. So this shows how analysis and interpretation of data can have a big impact on the perceived benefits and risk of a drug. So from the example of Neurosan and the prescribed drugs, what we're really trying to understand is the actual effect of these drugs. We're really trying to see whether there is a clear pattern of benefit and risk. Another way of thinking about this is by looking at this example in this slide. So imagine we've got a situation where we've got a coin, and if it falls heads, it's a 1, and if it falls tails, it's a 0. So let's toss the coin 4 times and look at the pattern. So let's look at the first line, and we see we have a 0 and 3 1s. So the question that arises is there a pattern here? Is it the case that there's systematically more heads than tails? And if you look at that, probably most people would think, yes, there does seem to be a pattern, that there's more heads than tails. And we then do it again, but this time we do it 8 times. And again, let's look at the pattern here. Is there a pattern? So we look at it, and yes, there does definitely seems to be a clustering of 1s and 0s. So we do the same thing time, but now we do it more times. And now if we look at the 3rd time, we can see that maybe it's not so clear whether there's clusterings or not. And again, we do it with many more trials, and we end up with this last time. And some people might think there's a pattern, some people might think there isn't a pattern. In fact, there is no pattern. It's just a random sequence of 1s and 0s because there's no bias in the coins. But it illustrates the point that we look for patterns, and so it's very easy to draw the wrong conclusions when looking at a small set of data. We really need large data sets before we can draw conclusions. And what this experiment shows is that we're really poor at identifying random samples. And that's why we need to do research to try to see whether really the effect of medicines is real, or is it just happening by chance. Sometimes we mistakenly spot patterns where no pattern exists. We expect to see too much alteration. Random sequences seem to be lumpy and ordered, which is why we think they are not random. As the quote in this slide says, "We can all be fooled by plausible sounding but false claims." One way of thinking about this is, what evidence do we need to look at in relation to medicines? In real life, we're often remarkably poor at estimating correlations because we generally pay too much attention to certain cells and not enough to others. Let's look at the table here showing the relationship between whether there is a full moon and the number of psychiatric hospital admissions. In particular, research demonstrates that we typically pay too much attention to cell A, that is there a full moon and the number of psychiatric hospital admissions, and we tend not to look at cell B, which is there a full moon and are there no psychiatric hospital admissions? And that's partly understandable because cell A seems to be more interesting than cell B. What's worse is when we don't pay any attention to cells C or D at all. So you can see how easy it is to draw false conclusions if you don't have full data set. Looking at the lower table here, I've just translated these principles into more abstract principles, which is, do we have data on whether a person is exposed to the drug, yes or no? And whether we have data on whether there's an outcome, for example, did they or did they not receive hospital treatment? And this is a really important table which underlies a lot of research in pharmacoepidemiology. And it's well worth bearing in mind whatever type of research project you're going to be doing. There are many reasons for faulty interpretation of data, and it's very important to be aware of these when you're looking at any study or planning a study. These are just some of them. So there might be a desire for easy answers and quick fixes. For example, the example that we saw with Neurosan. Or there could be example to a biased sample, as we saw in the last slide. For example, therapists may be prone to this error because they spend most of their working lives with an unrepresentative sample of individuals. Here's an example. Many therapists believe it's difficult for people to quit smoking on their own. Yet research demonstrates that many, if not most, smokers manage to stop without formal psychological treatment. These therapists are falling prey to what statisticians call clinicians' illusion because of their selective exposure to a particular sample. There could also be false interpretations because of exaggeration of a kernel of truth. For example, it's sometimes claimed that we only use 10% of our brains. These are exaggerations. It's true that we may not use our full intellectual potential, but that doesn't mean that we only use 10% of our brains. And finally, in this example, there's the situation where we infer causation from correlation. One example of this potentially is a relationship between cannabis and schizophrenia. It's extremely difficult to separate causation from correlation here. While it's true that many people with schizophrenia do smoke cannabis, it's difficult to know which came first, and for that reason we need to think about the kind of table that I showed you in the last slide. I'm just going to say a little bit about the material that's available to you on the KLE on research methods. So first of all, there's the lectures in PDF format and also links to all these videos. Secondly, there's information on the workshops that are part of this module. Thirdly, there are sample examination questions and more detailed information on questionnaire design. And fourthly, there's a link to the paper that will form the basis of some of the examination questions, And this is a typical epidemiological paper which appears in the journal Pharmacoepidemiology and Drug Safety. We're not allowed to put the full paper up, so I put a link to the paper which you should be able to download. So we talked a little bit about the types of observations that are needed in many pharmacy studies. The next step is to assess whether the data we have are valid and reliable. Validity implies the extent to which the research instrument that we're using measures what it is intended to measure. Are we really measuring health status, for example? One well-known example is from the field of intelligence testing, where there's sometimes controversy over whether the questions used in an intelligence test are actually measuring intelligence, or are they just, for example, measuring memory of certain facts. Reliability refers to the degree to which our measures produce consistent results when repeated measures are made. And a reliable instrument need not be a valid instrument. Just because something does produce consistent findings doesn't mean that it's valid. So if, for example, you're thinking about doing a questionnaire, these issues are very important. For example, is the questionnaire going to be anonymous? Is it going to be face-to-face? Are there issues with people telling the truth about certain issues? Does it matter if we ask the questions individually or in groups? What about the response categories that we're using? Are there enough categories? Is the word order important? There are many issues. In the example on the right-hand side of the slide, which is taken from a well-known health survey questionnaire, the SF36, we can see the answers to particular questions. So I seem to get sicker a little easier than other people, and we can see that there are 5 different categories. So you can see that whether this produces valid or reliable data may very well depend on exactly how the question is asked and how it's coded. A final issue which I just want to address is that of bias. We may have a valid and reliable questionnaire, but what about if the people that we're asking are not a representative sample? If I was to ask everybody in the class a particular question, but half of the class are not here and they're not typical, then would I have a biased sample? So reliability and validity and bias are all important things to think about, both in looking at research studies and also in constructing your own research study. This slide asks the question, does pharmacy research need statistics? And the answer is that it depends. First of all, what do we mean by statistics? Statistics can be used to summarize or describe a collection of data, and this is called descriptive statistics. This is useful in nearly all research when communicating the results of experiments or studies. In addition, patterns in the data may be modeled in a way that account for randomness and uncertainty in observations, and are then used to draw inferences about the process or the population being studied. And this is called inferential statistics. Descriptive statistics and inferential statistics together comprise applied statistics. Now let's look at the 2 quotes in this slide. The first quote says, if your experiment needs statistics, you ought to have done a better experiment. And what this really refers to is the fact that, for example, in a laboratory, you can apply a lot of experimental control. If you have control over all the variables, then you won't need statistics because there's very little uncertainty. Now, as we've seen in many situations, it's not possible to exert this level of control. For example, if we're looking at the relationship between, for example, cannabis and schizophrenia use, we can't control this experimentally. Or if we look at the relationship between smoking and lung cancer, we can't control this experimentally. So we can't do experiments in certain situations. The second quote refers to a different phenomena, which is where people are using statistics, mainly descriptive statistics, to provide evidence for only one side of an argument. And this is something that we see quite a lot of nowadays, where people use statistics selectively to try to support one type of an argument. So what this slide I think demonstrates is that statistics isn't one thing. It's a whole variety of things depending on the type of study that we're looking at. The quote on this slide is taken from a book called Pharmaceutical Statistics by David Jones. And the quote reads, "Within the pharmaceutical sciences, knowledge of statistics is required to interpret data generated from all types of physical and biological investigations. Examples include comparisons of the pharmacological activities of therapeutic agents, investigations of the agonist-antagonist activities of therapeutic agents, pharmacokinetic calculations and estimations." With inferential statistics, as we've seen, we're trying to reach conclusions that go beyond the immediate data for alone. For example, we use inferential statistics to infer from a sample data what a population might think. However, in this module, we're not going to be examining the underlying mathematics, but rather how to use and interpret statistics. Let's look at an example of descriptive statistics and their interpretation from a Sunday Times report in 2009. The headline read, "Heart attacks plummet after smoking ban." The Sunday Times stated that England's smoking ban had caused a fall in heart attack rates of about 10%. But nowhere in the article was a source mentioned, and no one was quoted as giving this figure. In fact, the study the newspaper referred to does not exist. And even the anti-smoking pressure group Action on Smoking and Health went to the unusual lengths of posting a notice on its website the following day to point out that the figures reported in the Sunday Times are not based on any research conducted to date. Although the story quickly went round the globe, nobody seemed to know where the figure come from. In fact, the source appears to be the number of emergency admissions for acute myocardial infarctions, shown in this graph on the right here, with the arrow indicating the start of the smoking ban. What is clear in this case is that the number of heart attack admissions had been falling for some time. Far from causing further dramatic cuts in heart attack rates, the ban appears to have had no discernible effects. So you can see how easy it is to interpret or misinterpret descriptive statistics. And for another example of this, you might want to look at an article that I wrote called "Does Alcohol Consumption Predict Future Health Among Older Adults?" Looking at are not just abstract, but relate to how we interpret statistics. And this is very important for you to remember when looking at evidence-based medicine. As it says here in the slide, being able to apply the basic statistical and mathematical tools to clinical papers is a key building block to critical appraisal and forming individual clinical decisions or policy decisions with confidence based on a sound evidence base. I'm just going to say a few words about your proposal and project. The scope of these is very wide, and this book mainly deals with practice-related projects, but it does have principles that probably are relevant to all projects. It's divided into various sections, and it looks at the ability to recognize research problems, knowing what questions to ask to address these issues, the ability to search the literature appropriately, the ability to choose research methods, knowing what data analysis are appropriate, the ability to identify ethical issues which may apply, and the ability to critically evaluate the research design, data analysis, and conclusions in the research literature. So these are all very important issues. For example, imagine you wanted to research methadone, which is a drug used to treat heroin addiction. There are many aspects of the methadone issues. Some are more sociological in nature, some are more pharmacological in nature, and some are more epidemiological in nature. So there's a huge variety of ways that one might look at methadone. For example, if we look at health policy, we might want to think, is it okay for methadone to be prescribed to a patient for many years? How might we go about researching this issue? Do we want to, for example, explore what patients think of methadone or what pharmacists think of methadone? What's the social and economic environment under which methadone is being conducted? What are the long-term effects of methadone? Is it effective in treating heroin addiction? So there are many ways of approaching a problem, and only by having a good overview of the problem is it possible to come up with a good way of formulating appropriate research questions. And this slide just emphasizes the learning objectives for the research methods, which are to develop knowledge and skills in planning out research, understanding a range of research design, learn how to carry out statistical tests, and interpret empirical data. So how are the research methods assessed? There are a few multiple choice questions from the core principles that we'll be looking at. And these questions will be asked within the Stage 3 Block 1 material. Typically, there are around 5 to 10 questions based on the research methods. And there will also be a few longer questions based on one paper that we're going to be examining detail in another session. So let's look at some examples of research projects. The first thing that we need to ask is, what is the main research question? Then, what type of method should be used to address this question, and what type of analysis would be required? There are many factors to consider. Should the study be qualitative or quantitative? Are there factors that might cause confounding so that the question is not really answered? And are the proposed data likely to have acceptable validity and reliability? I think the main thing to think about is the question adequately specified? In other words, is the study question or hypothesis vague or is it precise? The more precise that is, the easier it will be to come up with an appropriate methodology. So let's go through some examples and think of some of the issues involved. So the first question that we're going to look at, which comes from a student project, and the title was Over-the-Counter Medicine Abuse and Misuse, Pharmacists' Beliefs, Concerns and Management. So I've just put in 3 columns here, which are quantitative, qualitative, and a comment on the study. It's not possible to go into all the details of the study, but I just want to think about some of the issues. So if you're faced with a question like this, you might first of all think, well, what's the kind of methodology I want to use? Do I want to interview people about their beliefs, concerns, and management, which is a possibility, or do I just want to send out a questionnaire? And in this particular case, the student decided to send out a questionnaire. Perhaps it was easier to do. It might be easier to do a questionnaire rather than try to arrange interviews. There are issues concerned about this, which we'll look at in more detail. But in this particular case, what the student decided to do was send out a questionnaire consisting of 5 sections with a selection of open and closed questions. In other words, sometimes the questions have predefined responses, and other times the person can just write in their own comments. And in addition, a 5-point Likert scale was used, and respondents were asked to provide self-ratings for each medicine abuse and misuse consequence scenario. So quite a lot of time was involved in developing a questionnaire, which is something that you might want to think about. And obviously there are issues to do with the validity and reliability of these questions. And I'm just going to look at one comment from this study, which was that in a 2-week period, 71% of pharmacists received suspicious requests for things that they considered to be abuse, and 79% for misuse. So high levels of requests, and the underlying question is, are these data valid? Were the people answering the questions representative? So that's one example of a study. A second example is a study entitled "A Qualitative Study to Investigate Staff and Patients' Views of General Practice Repeat Prescribing Systems." And obviously you can see from the title that they decided to do a qualitative study. They could have decided to do a quantitative study, as this study did here. They could have sent out a questionnaire, but having looked at the literature and the issues, they felt that perhaps a qualitative study would be better. So what they did was semi-structured interviews with 8 patients of 1 general medical practice and 4 focus group sessions with 24 staff members from 8 different practices. So quite an extensive piece of work here, and you would obviously have to design a semi-structured interview schedule and then tape record all the responses. So quite a lot of work involved in a qualitative study. And just one comment, that the main findings were that staff felt under pressure when processing prescriptions, and practice staff were task rather than patient focused. So it might be that the type of information you're able to get from a qualitative study is different to the type of information you would get from a quantitative study. And the third example I've chosen is called the role of ethnicity in patients' attitudes about asthma and its treatment. And from the title you might think, well, if it's to do with attitudes, again, maybe qualitative study would be appropriate. But in this case, the student chose to do a quantitative study, and they created a structure questionnaire with a series of opinion statements with respondents being measured using a 5-point scale. And rather than looking at the results this time in the comments, what I've decided to focus on is the fact that having set up this study, difficulties were encountered in recruiting patients due to high non-attendance rates at the clinic. So you can see from these 3 examples that there are many issues that need to be thought about when designing a research study. So having looked at qualitative and quantitative research methods with some examples, we're going to explore this in a little bit more detail in this slide. And note that this is an example of a slide where I've indicated the type of things that might come up in an examination question. You can see down here I've put this phrase examination topic. So the kind of questions are concerned with general principles. This does not mean that other slides will not help you. They will, because they'll flesh out the examples. But they're really designed to reinforce the principles shown in the examination slides. So in terms of different types of research methods, there are a wide range. If we look at this slide here, we can see that what most people would think of as quantitative methods might include experiments when we're doing something in a laboratory and we get quantitative data. But there are also randomized control trials, which are obviously very important in deciding which medicines are going to be made available. And that would involve quantitative analysis and statistical methods. Then we have situations where we are making controlled measurements, but we're not able to randomize people. So this would be an example of a cohort study. And then we also have, as we saw in the last examples, we have surveys where we're using questionnaires with closed questions. And these types of surveys yield quantitative data, which we can then analyze. And fourthly, increasingly databases are being used to provide information on medicines and outcomes. So these are all examples of quantitative methods. Examples of qualitative methods are where we interview people with open-ended questions, or we discuss situations with focus groups of people, or there's a whole range of methods which are called ethnography, where we're basically observing people in their natural settings. And the thing about all of these methods is that they don't involve using statistical methods or numerical analysis. It's more describing what's going on in these situations. So there's a big difference between the qualitative and the quantitative methods. So imagine a study, for example, looking at pharmacists and job stress. How would we go about looking at that? We could use either quantitative or qualitative methods. As we saw in the last slides, there are different ways of approaching these questions. Or let's think about a situation we wanted to look at the effect of medicinal cannabis and pain relief. There are qualitative studies and certain conclusions might be drawn from these studies. Equally, there are quantitative methods where people don't know which medicine they're receiving. They may be receiving cannabis, or they may be receiving a placebo. And it could be that those kinds of studies yield a level of information that's considered more reliable. There are no hard and fast answers to these questions. Just going back to the ethnography category here, this is where we really look at in detail at a situation, and it might be, for example, taking observations in a pharmacy and looking at all the factors that are influencing what goes on in pharmacy. So research tends to talk of ethnographic approaches. There isn't a single method. Throughout the research methods sessions, there will be review questions, and in each case what I'm going to do is read out the question, give you a few sessions to think about the answer, and then in the next slide I'll show you the answer. So the first question is, which of the following is a qualitative research method? Is it a cohort study? Is it a questionnaire with closed questions? Is it a database, or is it ethnography? So that's something that we've looked at a little bit already, so you might have some idea of the answer. So in the next slide, I'm going to show you the answer. So the correct answer in this case is ethnography. Ethnography is a situation where we're collecting qualitative information. The other ones all involve collecting numerical data, so they are all quantitative methods, whereas the ethnography data might be video recordings or transcripts, but not data that can be turned into numerical values. So let's look at an example of a quantitative pharmacy practice study that uses a postal survey. The study is called Satisfaction and Stress Survey, Assessing Job Satisfaction and Stress in Pharmacists. So we can see what the aim of the study is. We know that it's a survey, so it's going to be using quantitative data. And the study uses a modified version of the health professional stress inventory, which is a long list of questions about stress. And it sought the views of pharmacists with regard to their job satisfaction and job stress. And it was sent to all pharmacists in Northern Ireland. And I'll just look at two results. One, which was that the overall mean stress scores were higher for community than for hospital pharmacists. So it's trying to make a generalization about one group of pharmacists compared to another, compared on their numerical values of their mean stress score. And also other parts of the questionnaire show that interruptions, excessive workload, and inadequate staffing were most stressful for both groups. So we get an idea of the aims of the study, how they went about it, and there are other details in the paper which I'll just mention, which are not shown in the slide. One is that the overall response rate was 39%. So one thing to be aware of is that in most types of surveys, response rates are not usually that high. So 39% might appear quite low, but many studies have lower than this. And that involves 766 respondents, so quite a high proportion, but we don't know whether they are really representative of all pharmacists. So that's one of the issues for the study. In terms of the results, the paper reports a statistical difference between the two groups. So this is where we're using statistics to measure the difference between the mean stress scores, and the test will establish whether we're justified in saying whether what we found in our sample applies to the whole population. Yes, and so the other part of the paper talks about regression analysis, which is a method that we'll look at later, which is tries to look at what factors are associated with stress. So quite a complicated study. There are many strengths of the study, but also perhaps some weaknesses in terms of the sample size, and also questions to think of in relation to the validity and reliability of the data. So this is an example of a different type of study. It's a student project, and it was called an investigation into students' perceptions of locum pharmacy work. And rather than using a questionnaire, which we saw in the last study, this time they used a focus group. And the aim was to explore the perception of locum pharmacy work among first and fourth year students. And the findings were that participants in both groups alluded to greater flexibility of a locum career, focusing on a locum career, allowing more time for family. However, there were concerns. So we can see that focus groups are good for getting information about what people think about topics, but it's not going to be numerical data as we saw in the last slide. Focus groups are unique because they allow research participants to interact and respond to each other. The output data can be affected by many factors, such as the group size and whether the group members all know each other. So it's been suggested that the ideal focus group size is between 8 and 12 participants. In designing the questions for a focus group, it's important that they are ordered and designed specifically to lead the conversation to key areas of interest. And it's been emphasized that there's a need to organize the questions to include an introduction, allowing the participants to think about the topic and to open channels of communication. Decisions regarding the use of question phrasings are also relevant, and it is advised that the moderator does not start with closed questions that shut down the conversation. So, as with quantitative studies, qualitative studies also have many issues to think about. Here's an example of the kind of data that we get from focus groups. And unlike quantitative studies, as we've said already, it's not numerical data. It's usually data that are organized in themes with different quotes. So here are a couple of quotes from that focus group. It's like really flexible and you can choose your own hours, and other members of the group agree by saying yes. I probably won't because I want security of the permanent post. I hope to have children. I want to have a permanent job with a contract and a salary. So here we can see examples of two different themes that are emerging and how the data are reported from a focus group. Question. So thinking about what we've just been talking about, let's look at the four options to this question. Which of the following studies is a cohort study? Is it A, a study in which cells are stimulated with three different types of growth-inducing protein? Is it B, a study of medical students who are followed through their course to examine association between lifestyle and exam results? Is it C, a study comparing end of year, final year exams with first year exams? Or is it D, comparing exam pass rates at 10 medical schools? So I'll give you a minute to think about that. And the answer is B. It's a study of medical students who are followed through their course to examine association between lifestyle and exam results. So remember that a cohort study is when we follow a group of people from beginning of follow-up to some outcome event, in this case, exam results. Randomized control trials are only designed to answer whether or not an intervention is effective. But there are other types of questions that we might want to ask. We might want to ask, for example, is there a particular subgroup for whom this intervention works better than another? And the problem is that randomized controlled trials may not have enough people to answer this type of question. So sometimes people turn to qualitative research methods to try and address these questions. The evidence won't be as strong quality, but they still provide useful information. So for example, qualitative researchers might ask, does this intervention work in a variety of healthcare settings? What might be the problems associated in trying to introduce this intervention through a health service? So we can see that although randomized controlled trials are important with regarding effectiveness, there are many other questions about the use of drugs that are also important and that need to be addressed. There are also many issues to be considered when considering whether a randomized control trial is suitable. This slide just shows some of these, but it's a complex topic, and you'll be looking at that in more detail in the evidence-based medicine part of the course. But just to have a look at a few of them, it might be unethical to randomize patients to an intervention for which there is evidence of harm. The extent to which randomized control trial results are applicable outside the RCT might vary. For example, what works in one country might not work in another. Characteristics of the patients might be important. It may be that some types of people were excluded from the RCT. Outcome measures may be important. They might use biological markers rather than actual clinical outcomes. And of course, randomized control trials can be expensive. There are also other issues. For example, it's difficult to study outcomes far into the future. One of the things that I'm looking at the moment is polypharmacy, when people get a large number of drugs, which may affect them years later. First of all, in both in good ways and in bad ways. But it's difficult or impossible to do a randomized controlled trial of polypharmacy. So in that particular situation, a randomized controlled trial is not a feasible methodology. So this slide examines some of the factors that can affect the validity of a randomized controlled trials. We've seen that randomized controlled trials are considered the gold standard, but a lack of external validity is one of the most frequent criticisms. In other words, the results that we see in a randomized controlled trial don't necessarily reflect the real world. The trials have been constructed in such a way that, for example, patients who, for example, have comorbid conditions, or the kind of patients who might actually get the drugs in the real world, are excluded from the study. So the use of exclusion criteria is very common, and it can make the study more feasible and reduce costs, but it doesn't necessarily reflect the real world. And also bear in mind that even in large pragmatic trials which have few exclusion criteria, recruitment of less than 10% of potentially eligible studies is quite common. So those patients who are recruited may differ from those who are actually eligible in terms of things like age and severity of disease. We'll have another review question now. Which one of the following factors might not affect the external validity of randomized controlled trials? Is it the selection of participating centers? Is it severity of disease? Is it exclusion of patients at risk of complications? Or is it the final one, D, patients are randomly selected from index conditions? So think about what might not affect the external validity of a trial. I'll give you a minute or two to think about this, and then we'll look at the answers. So the question asks which of these factors would not affect the external validity of a randomized control trial, and the answer is D. If we selected patients randomly from an index condition, that would be good, because that would mean that they would be representative of the population. If, for example, we selected them on the basis of severity of disease, for example, only choosing people who didn't have severe disease, or they were only selected from particular places, or we excluded people who are at risk for complications, all of these things would affect the external validity of the randomized controlled trial. So evidence-based medicine is usually based on randomized controlled trials. So we'll just look at an example of one trial. This is from a 2003 paper called A Placebo-Controlled Double-Blind Study of the Efficacy and Safety of Aripiprazole in Patients with Acute Bipolar Mania. So it's a long title, but it tells us a lot about the type of study. It tells us that it's placebo-controlled. So it's comparing aripiprazole to a placebo drug, and it's double-blind, meaning that neither the patients nor the people giving the drugs in the study knew what was being received. So that tells us a lot about the study. And we've already looked at the title. We know that it's in a group of patients with bipolar disorder, and subjects were either randomized to aripiprazole or placebo, and we can see that there's 128 in the aripiprazole group, 130 in the placebo group. I'm only going to look at a very small bit of this study. And the conclusions were that aripiprazole has significantly greater efficacy than placebo for the treatment of acute maniac or mixed episodes associated with bipolar I disorder in Asian patients. So very precise, going back to what we talked about earlier in terms of having very clear aims and objectives. So while randomized controlled trials are the gold standard in terms of evidence-based medicine, there are other kinds of studies, and it's good to be aware of these other types of studies. And also in terms of designing your own types of research project, these might be things that are worth considering, especially as people are increasingly turning to databases, which means you can't randomize people, but you can follow them up over time. So one typical type of study would be a cohort study where we follow a group of patients using aripiprazole and a group not using it, recording the outcomes of interest in a group over time. So the critical difference here is they wouldn't be randomized. They would be having the drug or not the drug, which may or may not be placebo, probably not a placebo. So that would be the big difference. They're not randomized and not necessarily receiving a placebo. The cohort is when we follow people forward. Another type of study is where we follow people backwards. We start with the outcome of interest. So we would look backwards comparing the exposure history of a group of bipolar patients who have suffered an episode, and then look backwards to see whether they'd had aripiprazole or not, and then we would see whether they differed in their use. So that's a case control study. The final type of study is where we don't look at individuals, but we look at, for example, two different places, and we look at their rates of use and their rates of adverse events, and we see whether these are the same or different. So that would be called an ecological study. So the difference is here we're looking at populations of people rather than individuals. So all these are different types of evidence, not as strong as randomized controlled trials, but nevertheless important for understanding how drugs work. So in terms of reading material for the course, there's a lot of information in these sessions. In terms of further reading, there are two main books. One is Conducting Your Pharmacy Practice Research Project by Felicity Smith, and the other one, which is more about relating statistics to research, is Discovering Statistics Using IBM SPSS by Andy Field, and that's what we'll be using in our workshop to demonstrate statistics. So just to summarize what we've been looking at in this overview, the first point is, what question are you trying to answer, or what question is a research paper trying to answer? And we've seen that there are quite often a range of methodologies. While randomization might be the gold standards, we can see that in many situations it's not possible. And furthermore, unlike laboratories, it's not always possible to have a high degree of experimental control. For example, if we consider the example of the effects of smoking on lung cancer, there's never been a randomized controlled trial. It would be unethical to randomize one group to smoke and one group not to smoke. So we have to rely on observational data. We've seen that quantitative research requires understanding of statistical and analytic concepts. There's no point in doing a quantitative study unless you understand the range of statistical methodologies, and this also applies to reading papers. Qualitative research, on the other hand, is dependent more on theoretical rather than numerical analysis. And finally, we've seen that there is a strong link between research methods and evidence-based medicine. So that concludes what I'm going to talk about in the overview of the research methods module part of the course.